I welcome everybody to this virtual discussion on an improved understanding of the cost effectiveness of genome sequencing for diagnosing rare diseases, implications for patients and providers, hosted by the Personalized Medicine Coalition. Today, we will be discussing the results of an economic modeling study examining the cost effectiveness of various genomics-based diagnostic testing strategies for patients with rare and undiagnosed disease. The discussion is hosted by the Personalized Medicine Coalition. I want to take the time to thank our partners for the economic analysis study, Tufts Center for the Evaluation of Value and Risk in Health, Nicholas Children's Hospital, Illumina, and Quest Diagnostics. And for today's webinar, our partner Ogilvy. Thanks to today's panelists, who I'll introduce in just a moment, and thanks to all of you, the audience, who share our interest in this topic and our goals in advancing personalized medicine. I am Daryl Pritchard, Senior Vice President of Science Policy at the Personalized Medicine Coalition, and I will moderate today's discussion. I'm joined by 4 distinguished panelists to discuss the clinical and economic utility of genomic testing for rare and undiagnosed disease in today's evolving healthcare delivery system. Today's discussion stems from, as I mentioned, a clinical and cost-effectiveness study on genomic sequencing to guide diagnosis and treatment of children with rare and undiagnosed disease. We utilized real-world practice-based data. The study was commissioned by the PMC and led by a research team at the Tufts Center for Evaluation of Value and Risk in Health. The research team was led by Tara Lavelle, who we've invited to present the findings and open our discussion about the implications for improved care strategies. Now, before I introduce the panelists, let me provide a short and broad background on the issue which we will discuss today. For patients with rare and undiagnosed diseases, genetic sequencing, that is determining a patient's entire unique DNA makeup, may be an extremely valuable tool for discovering the genetic alterations that contribute to disease development, as well as for influencing treatment decision-making where applicable. Patients with rare and undiagnosed diseases are often children who may have already undergone single gene testing, but still have not received a definitive diagnosis. This is often referred to as the diagnostic odyssey, as a child and family can bounce around various medical centers for years sometimes, while numerous diagnostic procedures are performed and healthcare costs are accrued. All the while, the disease goes undiagnosed. As they go through their diagnostic odysseys, these patients' diseases progress, and they lose time during which they could potentially receive effective therapies or be enrolled in a clinical trial. Sequencing information can also benefit researchers and clinical discovery by aiding in the development of improved diagnostic recognition of rare diseases. These diseases are often very rare, and we need more information to help us make an accurate diagnosis. And the development of potential therapeutic options in area of great unmet need. Now, despite an expanding body of evidence supporting the clinical value of genomic testing, it remains underutilized in newborn and undiagnosed disease settings. So, facing these challenges to its implementation, we considered a key consideration for stakeholders that provide access to sequencing. These are the providers and payers that really control the policies and practices that allow for patients to receive genomic sequencing. The key consideration involves recognition of the clinical and economic value that a sequence strategy can bring. Why should we do this? What is really the value of this strategy? So our team of clinical experts and health economists set out to utilize real-world data to examine the clinical and economic value. And we have gathered today to discuss the results and the issue. Now, I've seen the list of registrants, and many experts on this topic are in the audience. We're really appreciative for all who have joined. So we hope to make this an interactive discussion. And I urge you all to send your comments and questions to the panel via the Q&A feature within the Zoom platform. We will begin with a presentation of the results, followed by opening thoughts from all of our panelists. This will be followed by a discussion of the most pressing challenges and the path forward. and we will invite audience comments and questions. Now, with that, let me introduce our distinguished panelists who will provide their perspectives on the clinical and cost effectiveness of genomic sequencing for patients with rare and undiagnosed disease. First is Dr. Tara Lavelle, who is an assistant professor at the Center for Evaluation of Value and Risk in Health at Tufts Medical Center, who, along with Peter Newman, led this study and will deliver our primary presentation today, along with her thoughts and perspective on the implications. Tara will be joined on our expert panel by Dylan Simon, who is the Director of Policy, Every Life Foundation for Rare Diseases, and Dr. Daria Salyukina, who is the Director of Personalized Medicine and Health Outcomes Research at Nicholas Children's Hospital, and finally by Dr. Brock Schrader, Vice President of Global Market Access at Illumina, a key sequencing provider company, manufacturer. So with that, let me turn it over to you, Tara, to discuss the project.
Great, thank you, Brock, or Daryl. Let me share my screen here. Okay. Can everyone see that? All right, well, thank you. Thanks for everyone for joining. And as Daryl pointed out, I'm going to be talking about our paper that came out, our analysis on the cost effectiveness of exome and genome sequencing for children with rare and undiagnosed conditions. Around 5% of babies are born each year with a genetic disorder. And for many of these kids, their conditions may be suspected at birth, or for others, they may suspect the condition as they start to grow and develop. And some of these kids they can be diagnosed easily using standard methods, but for many they are, for many they undergo a long process of testing, and the result can turn into what Daryl referred to as this diagnostic odyssey. More recently, though, genome and exome sequencing have been increasingly used in clinical practice, and these tests allow clinicians to identify uncommon gene mutations that cause rare diseases and diagnose diseases that tend to be undetected by current standard of care tests. And recently, the American College of Medical Genetics and Genomics issued a strong recommendation supporting the use of genome and exome sequencing to diagnose pediatric patients, both with congenital anomalies and intellectual disability. But these tests are more expensive than other options, including things like single gene tests and even gene panels. And as a result, payers and other decision makers are struggling with this question of whether these tests, genome and exome sequencing, are worth the cost. And as a result, there's limited insurance coverage for these tests, particularly for genome sequencing, which currently is more expensive than exome sequencing. An economic evaluation can help payers and other decision makers determine how to best expand access to genome and exome sequencing, and figure out how to expand it to where the technology, where the cost warrants the benefits. And so far, though, there's been limited evidence that is showing the cost effectiveness of these technologies. The limited data that's available shows that exome sequencing may be cost effective, but few studies have looked at the value of genome sequencing, and few of these have actually been conducted in the US. So our goal is to examine the cost effectiveness of genome sequencing compared to exome sequencing, compared to standard of care for children with suspected genetic conditions. We did this analysis by looking at both the cost per additional diagnosis made over a 10-year time horizon, as well as the cost per quality adjusted life year, or QALY, gained over a patient's lifetime horizon. And for those on the webinar that aren't familiar with the QALY, it's a common outcome measure and cost effectiveness analysis that essentially weights each year of life following an intervention by its quality of life. So for today's presentation, I'm going to focus on the results that we conducted, or the analysis we conducted, in terms of the cost per QALYs gained over a patient's lifetime. We looked at cost effectiveness in two different patient groups. The first was infants under the age of 1 who were critically ill, and these are infants that you typically see in a setting like the NICU. And because of the severity of their condition, we assume that these infants underwent rapid exome or genome sequencing. The other group of children that we ran our analysis in was children under the age of 18 who are not critically ill. And we assumed that all these children underwent exome or genome sequencing with a standard turnaround time. So to conduct this analysis, we built this simulation model that compares 7 testing strategies to each other. All of our model inputs were derived from either the literature, Medicare reimbursement rates, or estimated lab costs. And as I mentioned earlier, we ran the model over a 10-year and a lifetime horizon. And we included healthcare costs only, estimated in 2019 US dollars. And one thing I wanted to note as part of this presentation is that this model is open source, and we hope that it can be used by other groups who wish to see whether these technologies are cost effective in their own setting and from their own perspective. So feel free to reach out to me after this if anyone would like access to this model and code, and we're happy to share that with you. So the 7 testing strategies that we examined were standard of care testing only, no exome or genome sequencing. Standard of care followed by exome sequencing if standard of care did not result in a diagnosis. Standard of care followed by genome sequencing if standard of care did not result in a diagnosis. Exome sequencing as a first-line test, genome sequencing as a first-line test, exome sequencing followed by genome sequencing if necessary, and standard of care followed by exome sequencing followed by genome sequencing if necessary. So here's an example of the model that evaluates standard of care testing for infants. So for standard of care testing, 9% of infants received a diagnosis, and 9% of children improved following a diagnosis. So this means that 91% of children were assumed not to receive a diagnosis under standard of care testing. And these children we assumed would continue to undergo testing, which of course is both costly for the healthcare system and a difficult process for the child and family. So here's an example of the arm of the model that evaluates exome sequencing for infants. So here we see that the diagnostic rate improves to 37%. Same as the last one, 9% of these kids improve, 91% do not improve. 63% do not receive a diagnosis, and there's no improvement. But importantly, as part of this model, we assume that regardless of the outcome, that this test ends the majority of testing for children, because there's not many other tests that can be run after exome sequencing, even if there's a negative finding. So this in and of itself is a huge cost saving for the healthcare system, and this was an influential factor in our cost effectiveness analysis. And the model for genome sequencing is similar. We assume that 49% of kids get a diagnosis through genome sequencing. Again, 9% see an improvement following this. 51% do not receive a diagnosis and do not have any improvement. And similar to exome sequencing, regardless of the outcome, this is assumed to be the end of the diagnostic odyssey for children. And this was an influential factor in our analysis. So there's very little information currently out there on what we should expect in terms of the long-term outcomes for infants with rare diseases. So we consider different scenarios for children who improved following the diagnosis and children who did not improve following the diagnosis. And so for children who did not improve following testing, we assume that critically ill infants who do not improve will have a lifetime of severe disability. And non-critically ill children who do not improve following testing will have a lifetime of moderate disability. So these were our assumptions in terms of the lifetime trajectories of these infants. And then for infants who do improve following a diagnosis, we considered these 3 possible scenarios in terms of how the improvement could impact their lifetime outcomes. And we ran our models separately for each of these scenarios. And so I'll be showing you the results for each of these scenarios separately. So the first and least optimistic scenario we came up with was that all infants would have a lifetime of moderate disability if they improve. So they would go from severe disability to moderate disability if they improved following a diagnosis. The second scenario was that half of the infants would have a moderate disability if they improved, and the other half would have a mild disability if they improved. And finally, our third, and this is the most optimistic scenario, was that a third of the infants who improved would have moderate disability, a third would have mild disability, and a third would have no disability. And so we made similar assumptions on the lifetime scenarios for older children. And these three scenarios are listed here in terms of the least optimistic, number 1, all the way down to the most optimistic scenario, number 3. And we ran the model separately for each of these scenarios. So first, I'm going to show you the results for the infants in our analysis. So I'm going to walk you through in detail the results for the least optimistic scenario, assuming that children who improve are moderately disabled for life. And again, this is our least optimistic scenario. So on the y-axis here, I have the expected cost of each strategy in US dollars. And on the x-axis here, I have the QALYs gained over a child's lifetime for each strategy. So first, our expected outcomes for standard of care is that it will have the lowest expected QALY gains, but also the lowest costs compared to all the other interventions. And next, the outcomes for modeling exome sequencing, we found that it's associated with around 14.13 QALY gains and around $566,000 of lifetime costs. Standard of care followed by exome sequencing has the same amount of QALYs, but higher expected costs. And so this is automatically not a good option for us to be considering. Genome sequencing was associated with a QALY gain of 14.19 QALYs and additional lifetime costs of $567,000. And these other strategies are all the same QALYs as genome sequencing, but had additional costs. So again, are not considered to be good options for us to be looking at. So in the end, the possible strategies that we are left to compare are either standard of care, exome sequencing as a first-line test, or genome sequencing as a first-line test. And all the other strategies we're going to eliminate from consideration because they don't provide any additional health gain over these strategies. So I just rescaled this graph here to focus on these three remaining strategies. So first, compared to looking at exome sequencing compared to standard of care, we see that exome sequencing has an additional cost of $19,664 per QALY gained. And genome sequencing compared to exome sequencing has a cost of $16,466 per QALY gained. And so one of the things to think about in cost effectiveness analysis is that we never want to pay more per unit of health for something with lower benefit. So that's what we see here with exome sequencing compared to exome sequencing compared to genome sequencing, is that we're having to pay more per unit of health gained. And so we want to eliminate exome sequencing as an efficient option and focus on genome sequencing compared to standard of care as our most efficient option to consider here. So when we recalculate and we look at the cost effectiveness of genome sequencing compared to standard of care, we see that, again, and this is our least optimistic scenario, that genome sequencing costs $18,877,000 per QALY gained over standard of care. So some people might ask, so what does this mean? So is this a good value for money? And in cost effectiveness analysis, we have benchmarks that we use to help us decide whether an intervention is a good use of our money. And in the US, the guidelines recommend that we use a range of benchmarks. And generally what we think about is that interventions that have a incremental cost effectiveness ratio, which is what I just showed you in terms of dollars per QALY gained, if that ratio is less than around $100,000 to $150,000, per quality gained, it's considered to be a cost-effective intervention in the US. So what this means is that even in our least optimistic scenario, which is what I just showed you, the results, which is that genome sequencing would cost around $900,000 per quality gained, is a good use of money, and it would be considered a cost-effective option for diagnosing sick infants with suspected genetic diseases. So I'm not going to go through the other scenarios in as much detail, but I just wanted to show you the results here. And essentially what you start to see is that as we become more optimistic in our assumptions about how much children would improve following a diagnosis, genome sequencing becomes more and more economically attractive. So I just showed you the first scenario, which is our least optimistic. Under a moderately optimistic scenario, genome sequencing is expected to cost around $9,000 per quality gained. And under the most optimistic projections about how much children would improve following a diagnosis, we estimate that genome sequencing would actually be cost-saving compared to standard of care testing. So next, I'm going to show you the results for children under the age of 18, and these are kids that are not critically ill, so they underwent exome and genome sequencing with a standard turnaround time. So here you can start to see the results that they look pretty different than what we saw in infants. And this is partly related to the fact that we assume that these children are not critically ill to begin with. And so genome sequencing in this population has less economic value than we saw with sick infants. And so you can look at our least and moderately optimistic scenarios that show that genome sequencing costs anywhere from $364,000 to $490,000 per quality gained. In these scenarios, genome sequencing would definitely not be typically considered cost effective in what we consider using our general US benchmarks for cost effectiveness analysis. But under the most optimistic scenario, that looks at the scenario and how much children would improve following a diagnosis, we see that genome sequencing would cost around $119,700 per quality gained. And this would mean that genome sequencing was a cost-effective intervention in this population. And just to remind you what this means, the most optimistic scenario assumed that the children who underwent sequencing that they would improve. So half the children that would improve would have a mild disability, and half that improve would have no disability. And only under this scenario would this intervention be considered cost effective. So just to summarize, we find that genome sequencing is more cost effective in critically ill infants versus non-critically ill children. And running standard of care tests before exome or genome sequencing does not appear to be a good use of resources. Genome sequencing is a preferred option based on value over exome sequencing. But it's important to point out that exome sequencing is nearly as efficient as genome sequencing. So in cases where genome sequencing is not available for any reason, exome sequencing provides nearly the same value as genome sequencing. But it's also important to point out that we did not include a lot of the long-term societal implications for children with undiagnosed rare diseases, just because we didn't have data on this. And this includes things like decreased educational and employment opportunities, as well as the quality of life and productivity of parents and others that care for these children. And there's really an urgent need for more research to be done in this area to really quantify these broader impacts on the family and society that can benefit from testing. And I think it's really important to keep in mind that this is a rapidly evolving and novel technology. And as the cost of exome and genome sequencing decrease and the diagnostic yield increases, the economic value of these technologies will increase. And I hope this is another way that our open source model can be used and to continue to update these parameters as they continue to evolve. I just want to thank my collaborators on this, and of course, funding from the Personalized Medicine Coalition. Thank you.
Thank you, Tara. Excellent presentation of a very important and impactful study. There's a lot to unpack there. There's lots going on, and we already have some questions from the audience about some of the methodology, how we measured some of the care strategy. But before we get into the Q&A, I want to invite our panelists to give their perspective on the issue and on the study. First, we'll start with Dylan Simon with the Every Life Foundation. And Dylan, you bring a terrific perspective into this, representing both a policy perspective and also a patient perspective. And that's why I wanted to start with you, so that we can understand what are the implications of this? What is your perspective on the issue related to patients and to policy? So Dylan, to you.
Yep, happy to jump in, and thanks so much for having me here today. And this is an important issue within the rare disease community. As many on this call are probably aware, the diagnostic odyssey is all too common within the rare disease community. It could take an average 6.3 years for a rare disease patient from their first symptom to receive their diagnosis. And in addition, it's estimated that approximately 70 to 80%, numbers vary a little bit in terms of what percentage of rare diseases are genetic in origin. And so obviously genetic testing can play such a huge role in ending that diagnostic odyssey. How do we find ways to bring down that time to diagnosis? And so seeing all this information is really great to see because it highlights what many within the rare disease community have expected for a long time, which is that genetic testing will be extremely helpful in that diagnostic process. But in addition, it's helpful just to know in terms of increasing data, increasing information, not only about the ability to provide the correct diagnosis, but the cost effectiveness can be really helpful moving forward in terms of coverage. Because too often what we're seeing is that coverage, genetic testing is being viewed as still experimental, and being able to show that it's not, and be able also to show that it's cost effective is really impactful in terms of the policy and advocacy side of this all. And so there's this bill that we advocate for in the Every Life Foundation, known as the Precision Medicine Answers for Kids Today Act, which is a bit of a mouthful, but it's HR 5989 for anybody tracking at home. And this would really work to improve genetic testing across the board, and it would do that through a variety of issues, with the main aspect being a demonstration project, which would ensure coverage for participating, 100% coverage for these tests in participating states. And I think the important part of that project, which I was really excited to see also within this paper, is that it's looking at broader genetic testing, not just whole genome or whole exome, but looking at, it would provide coverage for all available DNA sequencing genetic testing, because we recognize that depending on the rare disease, it depends on which test needs to be ordered. And so it was really nice to see, especially that last slide, we're talking about how we were able to show that whole exome sequencing was relatively close in efficiency to whole genome sequencing. Because what we want to ensure the fact is that we don't pick one test and say, let's make sure we cover whole genome sequencing, even though for various conditions, whole exome might be the best test to run. Because this is all fantastic technology. It's all so exciting, and count me in that group that's so excited about the potential of genetic testing and all that these technologies can do. They're so amazing, and I'm so happy to see this progressing. But we need to make sure that we're providing coverage for all of this genetic testing. And so that's, from the advocacy point of view, having information like this makes it a lot easier to advocate to policymakers, saying, some people are saying this is still experimental, but I have the data and I can show you that it's not. If you can couple this with ACMG's recent research around their recommendations on which tests to be running, it culminates into a really great advocacy story that says, we need these tests. We need these tests in the rare disease community and beyond the rare disease community to ensure the fact that we're getting the diagnosis we need to get to treatment. And so for me, it was really great to see all that. I think in addition, it really is important to highlight also with the Undiagnosed Disease Network, because that's such great work that occurs there, and it's such a big part of their of so many tools in their toolbox is genetic testing. And so the ability to utilize the variety of genetic tests to be able to show the importance of them will really help to increase the long-term funding for the Undiagnosed Disease Network as we continue to fight for their funding, because they play such a vital role as hubs around the country, as places for those on the diagnostic odyssey to go find experts who can help proceed that diagnosis and provide that diagnosis. And so really excited to be here to talk a little more about this today in terms of policy and patient perspective. But thanks so much for having me. Darryl, I'll pass back to you.
Thank you for that, Dylan. It really does help to us all to understand sort of the value that ending the diagnostic odyssey brings to patients. Absolutely, probably the most important perspective. So I really appreciate that. Let's turn to Dr. Daria Salikanya, sorry, Daria, who is the Director of Personalized Medicine and Health Outcomes Research at Nicholas Children's Hospital, who has been wrangling with this issue of delivering sequencing for diagnosis of rare diseases within her patient community for years. Daria, what's your perspective on the issue?
Thank you, Daryl. I think this study is very encouraging. Also, it's very helpful in having conversations with the payers and with healthcare administrators, because there are a lot of barriers in the implementation of whole genome sequencing in the clinic right now. Of course, as everybody knows, the reimbursement is spotty, but there are also a lot of barriers in the hospital, starting with kind of skepticism of the physicians that we have encountered 4 years ago when we just started. It took some time to demonstrate the value to the physicians and to make sure they're comfortable with ordering the tests and the test interpretation. We were lucky to get several grants, gifts, and state appropriation to run our program and to be able to implement it and fund it. But not every hospital gets this kind of funding, and it's really important to have the discussions about reimbursement, because whole genome sequencing has tremendous value for the families, starting with giving them answers, even sometimes the answer is not positive. And in fact, we see about 20% of these kids have lethal disease, and many of them have a rare genetic disease that doesn't have any treatment. Parents still express tremendous gratitude and tell us that this helps them to make informed decision to avoid unneeded testing that is not needed, additional procedures that are not needed, and looking for answers, sometimes for years. We also see that patients in critical care environment, in NICU and PICU, that the caregivers are very stressed and they're going through emotional roller coaster. And in fact, about 30 to 40% of them have clinical levels of depression or anxiety. So there is also an opportunity for health systems to approach the entire family, and not just the patient, not just the infant, but also think about strategies, how we can help these families, how we can help these caregivers, and what kind of services we're offering to them. Thank you.
Thank you, Daria. Another excellent perspective, having been dealing with the issue for a long time, but also, again, laying on the value. Tara talked a lot about the model and some of the economic inputs, but to take into account the value to the family in some ways that are harder to measure for developing metrics. Really want to talk about that a little more and really appreciate your perspective. Let's turn now to Brock Schrader, who's with Illumina and the Vice President of Global Market Access at Illumina, which is a key sequencing developer and manufacturer. And also, I've been working with for many years and has a unique perspective on the utilization challenges surrounding the use of genomic sequencing. So Brock, to you.
Thank you, Daryl. And thanks, Tara and Dylan and Daria. It's a pleasure to be part of the panel discussion. And it was an honor to work as part of the working team on the project. I thought I'd share a couple of thoughts here just to add on to what Tara and Dylan and Daria said. I'm representing, of course, an industry perspective on the panel here, but this population, children with rare and undiagnosed genetic disease, it's one that Illumina has focused on intently. I would say both from a technology development perspective, but also in terms of evidence generation. From the technology side, we, of course, at Illumina developed the sequencing instruments that are used for exome and genome sequencing. And I would say a key focus for Illumina over the years has really been continuing to innovate in that area and try to make the cost of sequencing, and in particular things like exome and genome sequencing, more affordable so that they can be rolled out more broadly in terms of clinical care. On the evidence side, we've really also been trying to work to develop the evidence base, both on the clinical side and of course on the economic evidence side. On the clinical side, a good example of this is last year, we, with collaborators, published the results of a randomized controlled trial, a study called NICU-seq, where critically ill newborns were randomized to receive either whole genome sequencing or usual care. And the results, which were published in the journal JAMA Pediatrics, were really striking. The babies that received whole genome sequencing were 2 times as likely to get a diagnosis and 2 times as likely to have active management changes based on that. So really the study was designed to not just look at diagnosis, but also what happens after that, whether there's a change in care. One of the things we also know from numerous other studies that I think is really important and critical for the conversation we're having here today is that many other studies have looked at the cost associated with that diagnostic odyssey, right? And have found that getting to that diagnosis sooner is likely to be cost saving to the system, right? Because over the course of the diagnostic odyssey, it's not just the genetic test, right? It's not just consolidating different genetic tests with one test. It's all the other things that take place over the course of the odyssey. It's genetic tests, but it's also imaging, and it's also specialist visits and other pathology tests that accrue over the course of the diagnostic odyssey. And the studies have been very consistent in showing that a more broad approach, an exome type approach, or increasingly a genome type approach, are likely to either be cost effective or, as I said, and we showed in some of the scenarios in this study, perhaps even cost saving to the system overall. I also thought I'd just add one more thought before we continue, and it's to add on to one of the things Tara mentioned. You know, in recent years, we've started to now see professional societies endorsing exome and lately whole genome sequencing approaches, not only the ACMG, the American College of Medical Genetics and Genomics that Tara mentioned, but recently the European Society of Human Genetics also endorsed whole genome sequencing and recommended it. And in addition, we've seen national healthcare systems reimbursing for these approaches, in particular whole genome. And this was this particular study was focused on the US setting, and we're talking mostly about the US setting. But I always think it's important to think about the types of thought process, in particular from a cost perspective and economic perspective, that other countries are looking at. So the National Health Service in England, the NHS England, which is of course well known to be conservative and focused on interventions that have proven clinical utility and proven economic utility, they've commissioned whole genome sequencing as a first-tier test for over 30 different clinical presentations, similar to the study population we were talking about here. Australia's Health Technology Assessment Agency has endorsed both exome and genome sequencing. Germany reimburses for both. Those are just a few examples, but it's unfortunately an area, and Daria hit on this, where I think the US has fallen behind other countries. Many payers, you know, more and more payers are paying for exome sequencing, but I would say the US has fallen behind in terms of reimbursing for genome sequencing, which was shown to be the most cost effective in this analysis. So, you know, my hope for this study is that it's a call to action, I think, for payers. It helps drive the conversation forward. It's an important discussion that we need to have as the field evolves, as the technology continues to develop. And I hope that it's a call to action for clinicians as well. And this was the last piece I was going to speak about. We recently published the results of a real world study that looked, and Daryl, you mentioned this, looked at the use of genetic testing in the US. So we used the Optum database, which is the United Healthcare data. And we looked at patients that had signs and symptoms of genetic disease. So ICD-9 or ICD-10 codes that looked like they might have a sign or symptom of genetic disease. And we found that in that population, only about 5 to 8% of patients that had these signs and symptoms were getting any kind of genetic testing. So not even an exome or a genome, any kind of genetic testing. So it's really a gap in care. And when you combine that with this evidence that has been established that the earlier you get to a diagnosis, it really decreases cost over a wide range of different types of costs. I think that's, there's an opportunity here to really improve the care of these children by getting to a diagnosis sooner and getting more kids to be able to have that diagnosis. So I'll pause there and we can get to the discussion. Thanks again for having me on the panel.
Thank you, Brock, for those comments, and thanks again to all of our panelists for your opening comments as we kind of shift now to a discussion. Let's bring all the panelists up onto the screen. We've already gotten a few questions from the audience, and at least 3 of them are related to what we've been discussing, the costs versus the benefits. And we know that the value accounts for net costs versus benefits, and that the stakeholders that we've kind of laid out as our primary audience, and that's the payers and the providers, those that really control access to sequencing and diagnostic technologies, are weighing that value question, cost versus benefits. And Tara, the study really did a nice job of laying out what are the values or what are the estimated costs for associated genomic testing, but also the costs to patients and society of undiagnosed disease. And as we balance these, how do we make that case to these key decision makers, payers, public policy decision makers, hospital administrators that control the investment in bringing genomic sequencing to their hospitals, clinicians and healthcare workforces? How do we bring that value proposition forward to them? And I just want to open this up to all, and again remind that I want this to be a conversation, so I'm not going to direct pointed questions to all of you, but hopefully we can all interact with each other and kind of get into this value conversation around costs and benefits. But I will ask Tara to go first on this one and then have the rest of you guys react.
Sure. Yeah, I'll just say that I think the results of our analysis were pretty striking in terms of, I'll just highlight the results in infants, and these are sick infants you would see in a NICU type setting, that under a wide range of scenarios, that this was really a very cost effective or cost saving technology. So I think if decision makers, a lot of times payers and decision makers try to, they try to address these things incrementally. And I would just say that from our results, very clearly, that is a group that really warrants this technology from an economic perspective, that it's a very clearly cost effective. And I will also just, remind people that this is likely an underestimate of the cost effectiveness, given that we didn't include things like productivity, education, parents' quality of life, which all are very important things to include. And hopefully we have more data on this going forward. But I think that right now, the evidence that we have just really shows that, at least for these sick infants, that this is really a very, there's a lot of evidence that it's cost effective.
We did get a follow-up question from Tom Pisani about the value to families, about that question. And do we have any insight as to what the views of medical ethicists are with regard to, ending the diagnostic odyssey and, what that value might be to society?
I can jump in just to say that I don't know if ethicists have addressed this, but there have been, a lot of additional studies that are going on now about what they call personal utility. So this is the value beyond clinical utility. And a lot of parents do value just even knowing, if their child gets a diagnosis, even if there's no treatment available, that they know what they have. They can put a name to it. They can connect with other families on Facebook groups. They can start to plan for the future for their child. And so there is a lot of just this knowledge that comes with knowing a diagnosis, that's a whole other component of value that we didn't include in here, but it's sort of is evolving research that's coming out in the field that I think is extremely important.
Yeah, I would just completely agree. I was going to add on to that or make a similar point. There's a number of different publications that use methodology called discrete choice experiments, right? Which is allowing to more of a quantitative measurement of the types of things Tara just talked about, personal utility, and parents and societies put a lot of value on those personal utility elements, including just getting to a diagnosis, even if there's not a cure. Of course, there's more value placed on it if there's a cure, but I think people also understand that the diagnostic odyssey in and of itself is such a challenge for families. It's such a challenge for patients. So ending that in and of itself has value, has economic value, which we measure, but it also has this sort of personal utility value. And one more thing I'd add there, I think we've actually seen U.S. payers and other national payers recognize that. If you look in coverage policies, you do see a recognition that the end of the diagnostic odyssey, really using diagnostic yield as an endpoint is sufficient in many of these policies, because we understand that gets to the end of an odyssey. So even though there may not be a survival benefit for many children that get a diagnosis, there's still that value that's recognized just to get to a diagnosis.
Definitely, and I want to build upon that a little bit in terms of what we're talking a lot about, in receiving that diagnosis and how important that is. Patient community having the answer can make all the difference. Those 6 years that you're searching for your diagnosis, there'll be doctors along the way who will not understand your symptoms. I think it's the nicest way I'll put it. And you'll just, within that same study that I referenced earlier, rare disease patients will see on average 17 specialists. And so that's going through the diagnostic odyssey. They're meeting with a bunch of different doctors. And so receiving that diagnosis from a intangible point of view, it can be so important. But from an economic point of view, because a lot of what we're talking about today is the cost effectiveness, the EveryLife Foundation conducted an economic burden of rare disease study. And looking just at 2019 data, it's shown that the healthcare costs associated with rare diseases totaled $966 billion. And the reason I want to bring that up is because 57% of that total cost was in the indirect and non-medical costs of absenteeism and forced retirement. And so the receiving that early diagnosis, especially in infants, it's so important to talk about that aspect. Is so yes, you're saving money on the direct medical costs, and I won't. That's a huge part of it. But we need to make sure we're also talking about the indirect and non-medical costs, because it can have so much downstream consequences, which is always nice to see. And Daria, sorry if I cut you off a little bit.
Yeah, I just wanted to add also that we did cost savings analysis, and also were able to show that we're saving between 100,000 and 200,000 per patient if we do this test on critically ill infants. We also have interviewed the families and the caregivers, and we see two major themes arising. One is the expectations of the diagnosis and expectation of changing or finding a treatment. And the other one is also understanding what the patient or parents are consenting to and the limitation of the test. Notice that often parents, when they are offered this test, they think it is going to answer all the questions and their child will receive a treatment. And it can be disappointing if there is no treatment. But even in this situation, we still see that parents see it as a very important information piece, because it makes a lot of planning possible and kind of stops their wondering what is wrong with their child. It also very important how communication is delivered, and that physicians show compassion when they do that. It can increase the utility and benefit of the test, and it can also be very traumatic to the family if it's not delivered in the wrong way, and can actually have opposite effect.
Right. Right. So we got a question from Nancy Finn directly related to that. So two kinds of subpopulations from the result of genomics sequencing or exome sequencing. and that's those that are led to a treatment and those that are not, where there's not really a treatment there, but for which we now have definitive diagnosis, and there probably is at least a reduction in further diagnosis, but there may be some change in care. To both Daria and to Tara, is there evidence that as these patients in both groups grow older, their healthcare costs are reduced? Tara, you kind of talked about the number of patients that can be led to a treatment. You also talked about the different assumptions, those that went from severe to moderate disability and those with no disability at all or mild disability. Is there any evidence to reduced healthcare costs associated with genomic sequencing at this point?
Yeah, to be honest, the long-term costs of genomic sequencing, we just need to be doing a lot more studies on that. So I would just say for anyone on this call who has, the options to, and this is something that we've been talking to the Undiagnosed Disease Network about, continuing follow-up for the families that are sequenced and continuing to collect data on their costs, because we did make assumptions in the model, given that there are treatments available for some kids that on average their healthcare costs are reduced over time. So I think on average, you probably will see that type of cost savings. But again, there's going to be a lot of heterogeneity there, and we need just better data to really characterize those long-term outcomes.
Yeah, from our own experience in study from Project Baby Manatee, we observed these patients for between 1 to 3 years, and we do see reduction in cost and downstream visits when they come back. There's also literature showing that if you do test early, if you do test in infants, it may bring more savings and benefits and changes in management than if you do the test when child is already 6, 7 years old. And we had another program where we offered whole genome sequencing for kids on Diagnostic Odyssey who have been looking for answers for 5, 10 years. And we can tell for sure that for older kids, we have not seen any changes in management or changes in healthcare utilization. But for the infants that we tested, we see changes in management in about 50% of cases.
Great, and you went ahead and answered another question we got from the audience. Julia Green asked, how important is it for testing to be rapid with normal turnaround time for achieving cost effectiveness? How did that figure into the model, whether they've got their testing early or late? And I know the answer to this, but I'm asking you to talk about the critically ill versus the non-critically ill patients.
In Tara's talk, you could see that if you test it early, then we definitely have better benefits, better savings. For our children, it is obvious that rapid testing gives you answers. Sometimes these kids are in such a critical state that physicians need to make a decision about a liver transplant or a heart transplant, or whether to proceed with some very costly and very complicated and very unpleasant procedures. They really need the answer as soon as possible. And we see the difference. If we get the answer within a couple of days, then there are changes. If we don't receive the answer for a couple of weeks, by this time, child may be deceased or discharged with some vague instructions. The biggest challenge for this, though, is that if we do testing inpatient, the reimbursement is following the DRG categories. That means that hospital receives the same payment whether we did the test or not. So technically, there is no incentive for the hospital to do the test. And most hospitals have to eat the cost or have some additional funding to support this. And I think unless this is somehow resolved, it will remain the biggest barrier for whole genome implementation in critically ill children.
Okay, and Brock, you
just to build on that.
Yeah, let me turn to you and also to follow up with an additional question. You mentioned sort of the outlook in other countries. How does this compare between other countries, especially as related to cost differences and for implementing genomic testing earlier?
Yeah, it's just, I can, maybe build on one thing and then answer that question. I think a number of US payers have started to try to address this question that Daria just brought up in terms of in the inpatient critically ill setting, how can we help ensure that this kind of testing is done given the reimbursement framework of a DRG-based payment. So there's some US payers that are making payments outside of that, so-called carve-out payments to help with that. But it's a challenge for hospitals to implement a test like this, in particular, as it's still a relatively new technology. So I think methods like that, while we're still working in that direction, are going to be very, very important. In other countries, I think there's a couple of things, that are at play there. One is that, and one of the questions I was just looking at was asking this question about, how have other countries implemented and what are the cost differences? As an internal team, we were talking about this the other day as well. When we think about costs in the US, we're often thinking about cost to the system in terms of what a payer, what an insurance company or a Medicaid program is paying for the test, which is more based on a contracted rate between a payer and laboratories, but may represent more than the cost to perform the test. In other markets, it may be more of a sometimes lower cost, as it is with drugs, which is what the question referred to, because in there it may really just be the cost to perform the test with less of a margin on top of it. So there's different ways to think about cost, and it's important in economic modeling, which we tried to do in our study, is be very clear about this, to highlight which are the costs that we're talking about. Are we talking about a reimbursement rate? Or are we talking about the cost to perform the test? And from our perspective, again, the industry perspective, we're trying to drive, over the years, the cost of sequencing down, and slowly that permeates into the market, right? It takes, it's less to perform a test, and overall rates come down. That's another area I think, it's great that Tara and the group made this an open source model, because over time we do see even those contracted rates in the US going down because the cost of sequencing goes down. It doesn't cost labs as much to do it. So we can go back in and say, how does this changed over time? The rates that we used from the Medicare fee schedule, the rates are less than that, and the reimbursement rates in many cases are less than that today. And so how does that change the equation?
Great, thank you for that, Brock. We are running out of time. We only have about 3 minutes left and a number of questions to go through, a number of questions from the audience and that we had planned on discussing as well. But let me turn to Dylan to hopefully give an answer to maybe what will be the last question. And that is, what is the current overall state of public policy related to rare and undiagnosed disease? And particularly, should we and how can we incentivize genomic testing use for undiagnosed disease?
I would say it's curious is where I would put the policy at the moment. I think there's a lot of understanding at the federal level of the possibilities that genetic testing has, but we're not quite there yet. There are a fair amount of genetic testing related bills introduced within the House and Senate, but we're not necessarily coalescing too much around one set idea. But it's nice to see the introductions. As I highlighted the bill earlier, that the Everlife Foundation supporting the Precision Medicine Answers for Kids Today Act, I think can really have a high impact. But I think in general around policy, what the main focus at the moment is just generating the data that we've been talking about today and really helping to go to payers and highlight the impact this can have. But when also doing that, going to policymakers and saying, this is why we think we should be going to payers. And so you kind of need the data you need for payers is often the same data you need for policymakers. And so I think where we are, it's moving too slow at times, but there is a platform. There is I guess the easiest way to put it is you'll have a welcoming ear when you bring this up. Policymakers want to hear about this. They want to talk about this, and they feel that this is something that they can start to move on. And I think they're just always a little hesitant to move too quickly on something like this and boxing out innovation. And so I think that's kind of where we are at the moment. It's just trying to find the best way forward.
Great. And Tara, any last comments before we have to adjourn on how to use this information, this analysis, the evidence that we've developed here to help drive policy towards genomic testing utilization?
Yeah, I mean, I think from our perspective, this analysis is really useful, just showing the value of this technology for the US healthcare system as a whole. And this is exactly the information that policymakers should be, prioritizing in terms of, we need to use the money the best way, the most efficient way possible in the US healthcare system. And this is, money well spent, particularly for infants in diagnosing, rare diseases.
Ask the panelists if we can, if we do have further conversation with audience members that can reach out to us, can we refer to them to each of you for continued dialogue and continued questions and answers about the study and about the issue?
Definitely.
Absolutely.
Terrific, thanks. So for everybody online, if you send your questions to us at the Personalized Medicine Coalition, we will continue to address it. Thank you all for joining us today. Thanks again to the panelists, to Tufts, to Nicholas, to Illumina, to EveryLife for your participation and for a great discussion today. Thanks all, and we will hope to continue to drive this issue forward as we move forward.
Thank you.
Thanks, everyone.